Now, after finishing up with Streptococcus pneumoniae, we'll now move on to Group A strep, or Streptococcus pyogenes. We'll start with some characteristics of this bacteria. So the first thing is it's a gram-positive cocci in chains. So unlike Strep pneumoniae, which is in pairs, Streptococcus pyogenes is found in chains. And a major protein that's involved and very critical to Strep pyogenes pathogenesis is the M protein. And the M protein is important because it's not only good for preventing phagocytosis, but it's also very important for how it's involved with rheumatic fever. So it's involved in the pathogenesis of rheumatic fever by something called molecular mimicry. So what does this mean? It means that the M protein mimics antigens in the heart tissue, and when the body makes antibodies against the M protein to fight against strep, it accidentally kills the heart tissue as well. And that's what causes the carditis associated with rheumatic fever. Molecular mimicry between the heart tissue and the M protein. So the antibodies made by the body can't tell the difference. Another important thing is pyogenic infections. So these are pyogenic, meaning they're purulent, full of neutrophils and pus, and they're caused by direct bacterial invasion and colonization. So what are some examples of infections caused by direct invasion and colonization? Pharyngitis, exudative pharyngitis, cellulitis, impetigo, erysipelas. These are all caused by Streptococcus invading into an area where it's not supposed to be and then colonizing that area. So now we have some toxin-mediated diseases caused by the pyrogenic or erythrogenic toxins that are made by Streptococcus. And these include scarlet fever, toxic shock syndrome toxin, and necrotizing fasciitis. So these conditions are all caused by toxins. Now we also have some immune-mediated diseases that are very classic for Strep pyogenes, and these are rheumatic fever and glomerulonephritis. So we'll talk about these soon, but these are very, very important. So why do we need to culture? The culture is important to be able to identify Streptococcus as the cause of our infection, Streptococcus pyogenes. So the important thing to find out would be a necrotizing fasciitis, very important because the body is dying and the muscles are falling apart. Pharyngitis, you can diagnose it early and prevent the complications, and scarlet fever as well for the same reasons. You want to diagnose strep and treat it immediately to prevent the complications in the future, such as rheumatic fever and glomerulonephritis. So whenever we have skin conditions, the cellulitis, erysipelas, impetigo, make sure to look up all these images on Google. They will help you so much to identify which skin lesion is which, and will make the test so much easier. And trust me, you're going to see a lot of rashes in the hospital. So the pyogenic diseases. Let's start with cellulitis. Alright, this is the first disease we're going to talk about. So what are some treatments for non-MRSA cellulitis? So some classic treatments for non-MRSA cellulitis. So this depends on if it's systemic symptoms or mild. If it's mild without fever, chills, hypotension, and other kinds of systemic symptoms, and it's caused by non-MRSA. If you're suspecting staph, methicillin-sensitive Staph aureus as the cause, you should use cephalexin or oxacillin or dicloxacillin. But if you're thinking of Streptococcus as the cause, you can just use a regular penicillin, IV or oral, depending on systemic toxicity. Remember, when you have systemic problems, systemic toxicity, you give IV antibiotics. Systemic toxicity meaning fever, chills, sweats, things like that. If it's mild and non-systemic, you just give oral antibiotics. So this is an infection of the deeper dermis and the subcutaneous fat. Alright, the classic thing here is deeper dermis and the fat. So it gets pretty deep into the skin. Some symptoms and signs. You have erythema, edema, and lymphadenopathy. So these are some signs of the infection of this deeper dermis and fat. A key indicator, though, is poor demarcation between the affected and unaffected skin. So we're going to see why that's very important. You can't really tell apart the affected skin and the unaffected skin. There's a very hazy area between these two pieces. Very slow progression of symptoms. It doesn't really progress that rapidly usually. And one thing to talk about this poor demarcation, it just means that it's not a sharp demarcation. It's a very dull, vague demarcation between the affected and unaffected skin. Now, a classic thing to suspect MRSA for is if you have a purulent cellulitis. If you have purulent cellulitis with pus underneath, you have to suspect MRSA and treat as well accordingly to MRSA. So in what situations do you suspect MRSA? This is very important to know because you'll be encountering MRSA all the time on the test and in the hospital. And the times that you want to suspect MRSA are if you have a recent hospitalization or exposure to healthcare facility. So if you've been hospitalized or exposed to healthcare, you could have gotten MRSA nosocomially. Another thing is having a previous history of an MRSA infection. You could get infected again. It could be living in your nares. And another thing is if you have major systemic toxicity or signs, you should suspect the worst and treat against MRSA, and then as an empiric antibiotic therapy. And when you culture it and find out it's not MRSA, you can narrow the therapy down to non-MRSA cellulitis. So those are some situations you want to suspect. Now, what are some oral drugs for MRSA? So remember, for most skin conditions that don't have systemic symptoms, you just give oral drugs for MRSA. So what are some drugs that do this? Doxycycline, trimethoprim sulfametazole, and clindamycin. So doxycycline, TMP, SMX, and clindamycin are very good oral drugs for MRSA that you can use if the cellulitis is non-systemically affecting the body. So no systemic symptoms and you suspect MRSA. Treat with IV antibiotics, and this is you do when you have systemic symptoms, fever, chills, hypotension. We've talked about this multiple times. Rapid progression of erythema. So if you have a rapid erythema and progression, which is not typical for cellulitis, that means there's some severe cause. So you need to treat with the IV antibiotics. So what are some IV drugs for MRSA? The IV drugs you should know for MRSA that are commonly used are going to be vancomycin as your first line and daptomycin as your second line. So remember, vancomycin, daptomycin. There are other drugs, but most likely you will not be tested on them. You should just know those two. Now, the thing that looks very similar to cellulitis but is different, erysipelas. All right, this is an infection of the upper dermis and superficial lymphatics. You see how these are different? These cellulitis affects the lower dermis and subcu fat below the dermis, while this affects the dermis and its lymphatics. So what are some symptoms and signs? Acute rapid onset, as opposed to cellulitis, which happens slowly. You can have facial involvement, butterfly malar rash-like, a facial involvement of the rash, and lymphadenopathy. Remember, the lymphatics are getting affected, so you have pretty prominent lymphadenopathy here. And a major thing is you have a bright red skin and a clear demarcation between uninvolved and involved tissue. So you have a very clear demarcation. You can see where it stops. Now, what's the treatment? Now, oral versus IV is the same as cellulitis. If you have systemic symptoms of rapid progression, treat with IV, or treat oral if it's a mild version. And remember, since strep pyogenes is the most common cause of erysipelas, if you have a high suspicion of erysipelas, you only need to give penicillin. Remember, Streptococcus pyogenes is still susceptible to penicillin. Now let's talk about some diseases that are associated with Streptococcus pyogenes. So the first classic one that we all know about that kids often get is pharyngitis associated with strep. So what are some symptoms of strep throat? You have exudative pharyngitis. So you have tonsillar exudates. So you have exudates on the tonsils formed by pus on the pharynx, and that's called exudative pharyngitis. You have cervical lymphadenopathy, so it's tender and inflamed, fever, and absence of typical URI symptoms. So this is very, very important. You want to differentiate strep pharyngitis from a typical cold. And the way you do that is by identifying that the viral URI symptoms are not present. What are some classic viral URI symptoms? A cough, a runny nose, conjunctivitis. Also, you have sneezing. These are all symptoms of viral URI. Those will not be found in pharyngitis. So if you have those typical viral URI symptoms, you should suspect a viral URI and not strep pharyngitis. So diagnosis. You only test if you're really suspicious for group A strep. If you think it's a viral URI, do not test. It's a waste of a test. So the time that you want to test is if it's a group A strep high risk, and throat culture is the best and preferred test. So once again, reiterating, do not test if the patient has viral URI symptoms. Very, very important. Remember, if you have viral URI, you just go home and drink fluids, rest, and it will go away on its own. So now there's another test called the rapid antigen detection test. So the throat culture is best, but you can still use this antigen detection test if you have at least 5 of the following. So only use the RADT if you have very, very, very high risk of group A strep and you're almost positive that it's it. So 1, age 5 to 15 years. Remember, it happens in younger people. Season, so during the late fall, winter. Tonsillar exudates or pharyngeal erythema. So remember, these are classic findings for Streptococcus pyogenes. So if you have that, that's another point added to at least 5. Greater than 1 centimeter tender anterior cervical lymph nodes, a high fever, and no viral URI symptoms. So there's 6 things here. If you have 5 of them, you can do a rapid antigen detection test, and if that's positive, you can identify this as Streptococcus pharyngitis and treat accordingly. But if it's positive, you don't need to do a throat culture. Because remember, you've already diagnosed a rapid antigen test with strep. What's the point of culturing it? You already know what you have. But if it's negative and you have a high risk, you should still perform a throat culture to figure out what exactly is going on. If you have all these symptoms, you should treat the patient. And what are you going to treat the patient with? oral penicillin or amoxicillin. Like we said, strep pyogenes is still sensitive to penicillin, so you can still give this to patients. Now, what if you have a mild allergy to penicillin, like a rash? You can give a first-generation cephalosporin like cephalexin or cefazolin. All right, if you're anaphylactic to penicillin, so you get a severe allergic response causing troubled breathing, hypotension, you can give macrolides such as azithromycin. So this is the treatment if you have anaphylaxis to penicillin for strep. Now let's talk about scarlet fever. So scarlet fever is a complication of pharyngitis, and it's not too bad. It's a pretty mild condition overall, but it can lead to some severe complications, and that's what we want to prevent. So how does this happen? You have the group A strep that causes pharyngitis. It gets lysogenized. Remember, lysogenized means that a bacteriophage, which is a virus, comes in and integrates into the genome of the group A strep, and that lysogeny allows a new gene to be entered into the bacterial genome, resulting in production of pyrogenic exotoxin. So the bacteriophage picked up some toxin genes from another bacteria, brought it to group A strep, and now this group A strep is producing this toxin, and that's going to cause the scarlet fever. So some symptoms of this. So within the first few days of pharyngitis, remember this is a complication of the strep pharyngitis, you get a diffuse sandpaper-like rash starting on the chest and spreading to the extremities. Classic presentation. Okay? What does a sandpaper-like rash mean? It means it's very bumpy and papular. So it's going to be red, bumpy, and rough. And that's what a sandpaper-like rash is. So take a look at this child's back. It's going to be a rough, red, bumpy back. So you have blanching maculopapular rash. So if you push on the red area, it'll turn white. And when you let go, it'll turn red again. That's what blanching means. And a nice key feature is that it's got circumoral pallor. It spares the area around the mouth. Remember, this is opposite to staphylococcal scalded skin syndrome, which affects the mouth. So it spares the mouth, palms, and soles. You won't see any rash in those areas, only on the extremities and the trunk. You also get a strawberry tongue, and you'll see this also in Kawasaki's disease. So it's a bright red and large tongue. And the diagnosis, same as strep pharyngitis, the same throat culture and rapid antigen detection test. And the treatment, same as pharyngitis. But the key thing is you need to treat these patients to prevent the complications in the future of rheumatic fever and glomerulonephritis. Another key feature is that after you start antibiotics, the kid can go back to daycare or school. The activity of the infection will not be very dangerous for other kids to get. So let's talk about this question now. So, which of the following is not true regarding this patient's condition? Remember, we always want to read the question first. Which of the following is not true regarding this patient's condition? So, temporary antibiotic prophylaxis is necessary in all patients. This condition can be preceded by a streptococcal skin infection, predisposed to AFib and stroke. Endocarditis prophylaxis is not required prior to dental procedures, and most common valvular abnormality is mitral regurg. So we want to find out which is not true. So let's see what's going on here. A 13-year-old girl presents to the emergency department with chest pain, pain in multiple joints, and nodules on her elbows. Alright, so she has chest pain, joint pains, and elbow nodules. So we should be thinking of a certain condition right now. Her parents are concerned about these symptoms. She remembers having a sore throat 2 weeks ago but did not seek treatment. So there's a history of a sore throat that was not treated. She is febrile, but vital signs are otherwise stable. She is hospitalized and treated with IV benzathine penicillin G. So first of all, what is this patient's condition? Yes, this is rheumatic fever. So let's talk about rheumatic fever and see which of these apply. A. Temporary antibiotic prophylaxis is necessary in all patients to prevent recurrence. Do patients with rheumatic fever history need to get prophylaxis? Yes, they definitely need to, because if you have rheumatic fever, you can get it again, especially if you get the carditis, which means you get inflammation of the endocardium, and if you have persistent valvular disease, you need prophylaxis for quite a few years to prevent future rheumatic fever endocarditis, because you don't want this condition getting worse and worse, because eventually, if you have enough episodes of rheumatic fever, the patient's heart could fail and they could die. So antibiotic prophylaxis is actually necessary in patients, especially if they have carditis or persistent valvular disease, to prevent recurrence of the rheumatic fever. This condition can be preceded by a streptococcal skin infection. Can a skin infection lead to rheumatic fever? No, it can't. That's a classic thing you need to remember, that streptococcal skin infections only lead to glomerulonephritis. They do not lead to rheumatic fever. So we can hold on to this one. Predisposes to AFib and stroke in the future? True. Remember, the most common valvular abnormality in rheumatic fever is mitral regurgitation, which is true. But over time, because of calcification and further damage to the valve and fibrosis, it can lead to a mitral stenosis. And that can cause the atria to enlarge, leading to fibrillation due to stretching of the atrial electrical fibers. And that can lead to a stroke in the future due to clot formation. Is endocarditis prophylaxis required prior to dental procedures if you have rheumatic fever? No, it's not. You don't need to worry about endocarditis prophylaxis with rheumatic fever. So our answer is B. All right, let's keep going. So now some more diseases caused by Streptococcus pyogenes. There are a lot of these diseases. So necrotizing fasciitis. So this is commonly associated with streptococcal toxic shock syndrome. Remember, necrotizing fasciitis is triggered by the actual toxin, so it can be associated with the toxic shock syndrome as well. So it's an infection even below cellulitis, below the subcutaneous fat, even into the muscle fascia. So the subcutaneous fat and muscle fascia being affected. Interestingly, the overlying skin can actually be unaffected initially, and it may just be a deep infection. So you always have to be worried about Streptococcus pyogenes-induced necrotizing fasciitis, even if the skin is unaffected, if you have certain symptoms that we'll talk about. A nice key thing to remember is that if you have cellulitis or overlying skin being normal but a lot of pain in the area and hypotension sepsis, you should consider there being a necrotizing fasciitis caused by strep pyogenes. And especially if there's a cellulitis present and you have hypotension and systemic signs, you should suspect necrotizing fasciitis. So there are two types. Type 1 is polymicrobial with at least one anaerobe, and type 2 is one we'll be talking about, group A strep. So what are some signs and symptoms here? We have erythematous, poorly demarcated, swollen, tender skin. This resembles cellulitis, but cellulitis won't be as tender as this will be, necrotizing fasciitis. You also have pain out of proportion to the physical exam. So the physical exam findings seem mild. They can even have normal overlying skin, but you have severe pain. So a nice key feature here is pain out of proportion. And even you can get an anesthesia of the skin and the area that's being damaged. And the reason why is that the nerves are being destroyed. So you can get anesthesia of the skin. And also, due to the death of skin and the extreme nature of the necrotizing fasciitis and the extent of the destruction, you can even get fluid leakage and bullae and gangrene as a result of death of the skin. And that's what we're going to be worried about and we need to treat immediately. So diagnosis, how are we going to diagnose this? So if we're suspecting necrotizing fasciitis, the best way to diagnose it is actually cut it open and debride it and explore it. And when you debride and explore it, you can see what exactly is going on, see the extent of the injury, and also culture the wound in the blood so you can find out what specifically is causing it, if it's type 1 or type 2. Elevated creatinine kinase levels. Remember, this is affecting muscle fascia, so the creatinine kinase will go up as well. You also need to give hemodynamic support because they'll be having hypotension, tachycardia, fever, and broad-spectrum empiric antibiotics because we want to treat for this condition. It's very severe, and even though the strep pyogenes may be causing this, other bacteria may superinfect it because of the opening to the surface and the severe nature of the injury. So we give carbapenems. Carbapenems are going to cover for gram-negatives and also for anaerobes, and beta-lactams plus a beta-lactamase inhibitor. These can cover for gram-positives and gram-negatives and anaerobes. Remember, the beta-lactam is a beta-lactamase inhibitor. An example is piperacillin tazobactam or ampicillin sulbactam. And the beta-lactam will cover the gram-positives, and the beta-lactamase inhibitor will help against the gram-negatives and the anaerobes. Clindamycin will also be used in addition to one of these, one or the other, because it has antitoxin effects. So something you may not have known before, but clindamycin actually is antitoxin and will help with this condition, which is caused by a toxin. And also give an anti-MRSA drug like vancomycin. So all three of these are needed for the empiric antibiotic therapy. So major complication that can occur with this is compartment syndrome. Remember, you're going to get really swollen and a lot of damage and inflammation in your muscle tissue, which can narrow the space and cause a compartment syndrome. So important thing to remember is suspect this condition if you have a high fever, hemodynamic instability, hypotension or tachycardia, rapid clinical progression, and elevated CK. So if you have these, always suspect this condition. And another thing, like I mentioned before, if you have something that looks like a cellulitis with major hypotension and rapid progression of symptoms, suspect necrotizing fasciitis. Now we'll talk about rheumatic fever. So rheumatic fever is another sequelae of group A strep pharyngitis, similar to what we've already talked about, or we're going to talk about actually, post-streptococcal glomerulonephritis. So these are immunologic sequelae to group A strep pharyngitis. Remember, this cannot happen after a skin infection. It happens about 2 to 4 weeks after a throat infection, and it's not associated with skin. Symptoms. There are major criteria involved here. There are 5 of them. Carditis, endocarditis, myocarditis, or even pericarditis. All of these can happen. And what's the most common valvular finding associated with the carditis? We talked about it in the question. It's mitral regurgitation. Good. So what can this lead to? If you have damage to the heart, inside, middle, and outside, you can get major heart failure. And the mitral and aortic valves are commonly affected, and you can have difficulty pumping blood forward, leading to a decompensated heart failure. That could even lead to death. So the initial regurgitation, remember mitral regurg is the most common regurg associated with rheumatic fever. It can lead to stenosis over time due to fibrosis and calcification. Now we also have something called synonyms chorea, or St. Vitus dance. This is a sudden involuntary movement similar to chorea from Huntington's. And you can also have associated emotional disturbances and strong emotional reactions to mild stimuli, like sudden outbursts of crying or laughter. Erythema marginatum. This is similar to the bullseye rash in Lyme disease, or even the erythematous rash associated with drugs, erythema multiforme. So it's going to be a pink truncal rash with central clearing, and it is not itchy. Okay, and now subcutaneous nodules. You've got nodules below the skin, and this usually involves the elbows, and we saw that in our case that we saw with the little girl. Migratory polyarthritis. This is usually the first symptom you're going to see, and you have multiple joints being affected, and you have transient pain. So one joint is hurting, then another joint hurts, maybe multiple joints are hurting, but it keeps on moving from joint to joint, and this resolves with NSAID use, anti-inflammatories. So the diagnosis is the Jones criteria. So the Jones criteria says that if you have 2 major criteria, like 2 of these, or 1 major and 2 minor criteria, you can diagnose with rheumatic fever. So what are the minor criteria that we need to know? The minor criteria are 1, a prolonged PR interval, 2, elevated acute phase reactants such as ESR and CRP, and also having a fever. Those will be your minor criteria. And they're listed at the notes section below this slide when you look at the presentation on your own. Treatment. Remember, rheumatic fever is caused by strep. You can just treat with penicillin G. The nice thing about strep is it's not very resistant, so you can give benzathine penicillin G to cover this condition. Now, how are you going to prevent it? So obviously you need to treat household contacts so they don't get group A strep also. So if they have a positive throat culture, you should treat them with penicillin. And also, you want to treat strep pharyngitis within 10 days of presentation. Otherwise, you can get rheumatic fever and have major problems. So treating strep pharyngitis will prevent rheumatic fever, but an important thing to know is it will not prevent post-streptococcal glomerulonephritis. So some antibiotic prophylaxis post-resolution. You can give some IM benzathine penicillin G on a weekly or monthly basis to prevent rheumatic fever from happening again. Remember, we talked about if you have carditis and you have major valve abnormalities, you want to prevent the rheumatic fever from happening again because you don't want this to get worse. So you can give antibiotic prophylaxis after the rheumatic fever resolves in those groups of patients. So now, our last, finally, disease caused by Streptococcus pyogenes. So this is a very major disease that causes lots of problems. So streptococcal glomerulonephritis can be caused by a prior pyoderma, so a skin infection, or a pharyngitis. So rheumatic fever can only be caused by a previous pharyngitis, while PSGN can be caused by either. So it's a type 3 hypersensitivity, immune complex formation and deposition in the glomerulus. So you have immune complexes forming and depositing everywhere. That's what causes PSGN. Remember, PSGN cannot be prevented by treating pharyngitis or pyoderma in time. Just like we said, no prevention with early antibiotic therapy. What are some symptoms and signs? So you have a glomerulonephritis, or inflammation of the glomerulus. And what does the glomerulus do? It filters blood. So if you have inflammation, you can get blood in the urine because it leaks through when it's not supposed to. You can get protein in the urine because you get damage to the protein charge barrier, leading to protein loss. You get hypertension and edema. So why do you get hypertension and edema? So edema can be caused by the loss of protein. When you lose protein, you lose oncotic pressure, so fluid can leak out of the vasculature into the interstitial space. And you can also get it because if you damage the glomerulus, you decrease the surface area available for filtration, and that decreases the GFR. So more blood will remain in circulation instead of being filtered through the kidney. So that's why you get hypertension and edema. You have more blood and more fluid inside of the vasculature. Diagnosis: you don't usually need a renal biopsy. The diagnosis is usually through different forms of microscopy if you do a renal biopsy, but otherwise you just look at it clinically. So say we do have to do a renal biopsy and we need to do a microscopy of it, what will we see? We'll see capillary proliferation, a diffuse involvement of the capillaries, and neutrophilic invasion. Remember, this is an inflammatory disease. So look how thick all these capillaries are. They're so thick and pink. So this means that there's a thickened capillary here, and also the pink is a deposition of different complement and different factors. But look how pink the whole area is. You have the bright pink and you have the light pink. The light pink is how thick the capillaries are. The bright pink is all the deposition. And you also have a lot of neutrophils and other cells invading as well. Immunofluorescence: you'll have granular IgG and C3 deposits in the capillaries and mesangium. And why do you get this? Because these are activated by the immune complex deposition. You're also going to have electron microscopy findings. You have something called subendothelial immune deposits. So below the endothelium of the cells, of the vasculature, below the endothelium of the glomerulus, you can get immune deposits that cause complement activation and inflammation. So all these bright pink things are deposits of different immune complexes which are activating the immune response. And you also have subepithelial humps that cause epithelial damage and proteinuria. So you can have damage to the podocytes, and that can lead to proteinuria due to loss of the charge barrier. You can do anti-DNase B antibodies for post-strep glomerulonephritis, but not anti-streptolysin O. And the reason for this is that anti-streptolysin O actually gets inactive. So streptolysin O itself, the toxin made by Streptococcus, streptolysin O, gets inactivated by cholesterol in the skin. So if you have inactivation of the streptolysin O, you can't make antibodies to it. So for post-strep glomerulonephritis, which can be caused by pyoderma or pharyngitis, DNase B is a better antibody to test for because this can detect both a previous pyoderma or a previous pharyngitis, while ASO cannot detect a previous pyoderma. So another thing you get are decreased C3 levels because they're all being converted to C3a and C3b, and decreased renal function because we talked about how the glomerulus is being damaged and the GFR drops. Urinalysis will show dysmorphic red blood cells, red blood cell casts. These are classic for glomerulonephritis, so always look for these on urinalysis. How are we going to treat this condition? So there's no specific treatment for post-streptococcal glomerulonephritis. It usually resolves on its own, but sometimes it can get worse and worse and cause progressive renal failure and death. But most likely that's not going to happen, and you just have to give supportive care and take care of the patient. And how are you going to do that? You have sodium and water restriction because you have hypertension and edema, and also give loop diuretics to treat the fluid overload. But a key thing to know is that this can lead to crescentic glomerulonephritis, which is end-stage renal failure.